participate in this afternoon's learning session. We've been really eager to have this session in particular because today we're going to be discussing something that's top of mind for most of us in the work that we do, of course, but also in the decisions that we're making about how to go about our day-to-day life. And it's the Delta variant. As a learning community, we have lots of questions about Delta, not just about the science of the variant and the COVID-19 vaccines, but also how to translate what we know about the Delta variant into messages that will resonate with the communities that this program is trying to reach. So for the next 45 minutes or so, we're going to have the honor of chatting with Dr. John P. Moore, who's going to share information about the Delta variant and try to answer as many of your questions as he can during our time together. I'm going to introduce Dr. Moore in just a moment. But first, a quick review of how this session is going to work. So you've all been muted upon entry to the session. There are lots of us, so staying on mute unless you're speaking is key to keeping the discussion going without accidental interruptions. Because this learning event is completely dialogue-based and focused on questions and answers, there won't be any slides beyond this first couple that I'm showing. We do want you to have the opportunity to speak your question rather than type it into Q&A. It's your choice whether you want to speak it or type it. But if you do want to speak your question, use the raise hand feature and we'll unmute you. So that's at the bottom in your toolbar. And if you want to type your question, of course, you can use the Q&A tab to do this, and you can ask the question at any point during the session. Once Dr. Moore takes over, I'll be focused on the Q&A and getting the next question ready. The chat room feature is also open today, and we encourage you to chat amongst yourselves as you'd like, but please use good chat room etiquette. And by this, I mean, don't post questions for the speaker in the chat room because we might not see them there. And though this probably goes without saying, please be civil to one another and to our speaker while chatting. And finally, as with all of our learning events, we will post the recording and a transcript of this event on our community website. And because we know not everyone has been onboarded to the website yet, some of you haven't received your invitations, we'll also send this through an email that's coming from your CDC project officer or the national organization that's supporting you, whoever you're used to getting our learning community announcements from. So that is it. Well, there's one more thing actually, which is that if you need help during the session, send an email to our community manager's inbox. That is vaxequitylearning@urban.org. And Luis is going to be watching the inbox while the session's going on, and he'll try to help you as quickly as he can. All right, so that's all I have for housekeeping issues. And let's get to the main attraction for today. So I'm pleased to introduce you to Dr. John P. Moore. Dr. Moore is a tenured professor of microbiology and immunology at Weill Cornell Medicine in New York. He received his undergraduate and graduate degrees from Cambridge University in the United Kingdom. And he's known for his research on HIV/AIDS, specifically the HIV-1 envelope glycoproteins. He previously worked on, at the Aaron Diamond AIDS Research Center and directs several NIH and other sponsored grants. Dr. Moore, thank you for being here today.
It's a pleasure. In fact, it's an honor to help you guys because the work you're doing is so extraordinarily important at the moment. So I'll certainly answer any and all questions I'm capable of. Yeah, my background is in HIV vaccines and virology. Both last year, as with many of my colleagues, we all had to learn how to spell SARS and COVID and get into a new virus and become knowledgeable about what's going on around us because we're all affected by the pandemic. So over the past year, I've done a lot of outreach to journalists and community groups about the pandemic and the virus that is spreading amongst us. I've also got experience from the early 2000s about dealing with the AIDS denialists who were around in those days and more so than now, and saying that AIDS drugs didn't work, that HIV didn't exist, didn't cause AIDS, etc. And we're hearing the same nowadays from COVID vaccine refusers. So there's little I haven't heard before. So I've been asked to kick off with a discussion about the Delta variant. The Delta variant is now the American pandemic. There's essentially very few cases that are being found that don't involve Delta. So where did it come from and why does it spread so rapidly? Well, the concept of a more transmissible variant is actually not new. we saw this in March and April of 2020. The original variant that spread from Wuhan into the west coast of America and Europe, and from Europe to the east coast, was very rapidly replaced by a new variant that we call D614G. Didn't have a Greek letter, it's now essentially a thing of the past. But that was a more transmissible variant. And within a month or two of its emergence, it became the dominant global pandemic virus. So over last summer, it spread through America, and most of the infections in the summer wave and into the fall with D614G. And we didn't really pay that much attention. It was, yes, that happened. Yes, it could happen again. But then the next more transmissible variant came along called Alpha. Now that arose in Kent in the UK in around September, October, and became the pandemic virus in England and Scotland, Wales, and drove the January wave that was a very destructive wave in many countries, including here in the States. And it was all done by Alpha. The Alpha variant squelched out, it outcompeted what came before. So the more transmissible virus always has an advantage and essentially outcompetes less transmissible viruses. So the January wave was all about Alpha. We then started to see globally other variants, beta and gamma, epsilon, lambda, you go through the whole Greek alphabet at some point. But these variants had a degree of antibody resistance, not an ability to completely evade vaccines, but the ability to partially get past antibody immunity. They were partially resistant. And they started to make us concerned because they were transmissible and they had a degree of antibody resistance. And they started to spread in the States. You might have heard about the California variant, the New York variant, what used to be called the South Africa variant, the Brazil variant. They're now called beta and gamma. And they were an issue in the first several months of this year. They're much less of an issue now because Delta emerged. Now, Delta first emerged in India, something like February and March, thereabouts, and triggered a devastating wave in India. The death count in India has been seriously undercounted, but Delta probably killed millions of Indians. It then spread into Asia, dominates the Asian pandemic. It spread into Europe, soon became the dominant strain there, spread from Europe into the USA, and we're now seeing the Delta pandemic. Its proportion of the cases rose inexorably over the past couple of months. And essentially, as I said earlier, the American pandemic is the Delta pandemic at present. Now, Delta is the most transmissible variant we've yet seen, which is why it outcompeted anything that was here before. It has a degree of antibody resistance. It's not as bad as the South African beta variant, but it's out there. Alpha wasn't particularly resistant, but Delta has some. So there is a concern that it is both more transmissible, which means that you're more likely to be infected by someone who sheds Delta virus from their nose by sneezing and breathing. If more virus goes out, the chances of you breathing in an infectious dose by a shorter exposure increases. It's just a numbers game. There are estimates that there is more, about 1,000-fold more Delta virus in the nose of infected people than we previously saw with other variants. The number's a bit fuzzy, but there's a lot more virus there. So if there's more virus in the nose, there's more virus breathed and sneezed out of the nose. And if you're in proximity and you're not wearing a mask, you're more likely to breathe in a dose that will infect you. It's really that simple. It's just a numbers game. Number of particles breathed out, number of particles that can be breathed in, increasing chance of infection. Delta is blockable by the vaccines. The vaccines are still stopping most people ending up in the hospital, in the ICU, and in the morgue. It's not unheard of for vaccinated people to die of Delta. You may well read ill-informed scare stories in the media because this makes news. You know, people not getting infected doesn't make news. People getting infected, especially if they die, makes news. So the media always tends to focus on, you know, rare events and take them as being general. So there are examples, no question, of vaccinated people who are sick, seriously sick with Delta. But the numbers strongly show that the vaccines still protect against Delta severe infections and death. There will be a degree of breakthrough, but the vaccines are not failing to protect people from severe disease and death. There are more at-home infections with Delta that are being seen. Again, the numbers, the percentage decrease in vaccine efficacy for mild infections, they're changing, they're evolving, they're being analyzed, they're coming in from Qatar. There was a paper from the Middle East, there's data from Israel, there's data from Britain, there's data from the CDC with different vaccines, different degrees of efficacy reductions. So they're out there and they're still being digested, and there's no doubt that there are more infections with Delta of vaccinated people than previously. But again, it doesn't mean to say that vaccines are failing completely. They're certainly not. And we're talking here about at-home mild COVID infections, a couple of days of, you know, bad colds and sore throat, that kind. But most often people are not finishing up in the hospital. So there's this perception in the public that vaccines always prevent infections. In fact, they don't. Most usually, vaccines prevent disease. They don't always prevent infections. And the public, you know, has a false perception on this. So what we're seeing with Delta is some infections, but little disease for vaccinated people. But for the unvaccinated, we're seeing a devastating wave of the pandemic. There are 100,000 to 200,000 Americans walking around today who will be dead by Christmas because they have refused to be vaccinated. And this is so transmissible that you can run, but you can't hide. Delta will find you at some point, unless you're living in a basement and you know, literally not going out of doors. It is a very transmissible variant. Vaccination is the protection against it. And if you're not vaccinated, you're really gambling with the lives of yourself, your family, your friends, your school colleagues, wherever you're working. So getting people vaccinated is absolutely imperative, because the unvaccinated are now driving the American pandemic with all its consequences to the economy, to society, and to public health. So that's my initial spiel, and I'll answer questions on any of what I've said and any other topics that you want to bring up.
Wonderful, thanks. So I encourage, if you have a question, raise your hand or type it in the Q&A. We did have a call for questions on our website for those of you who are on it. So I'll ask the first question while we're gathering others. We've gotten a couple questions or interest in kind of communicating about changing mask guidance. So I wondered if you might share any thoughts you have on the fact that mask guidance is changing, restrictions are easing in some states. So any thoughts or advice for our group on kind of communication around all of these changing guidelines, especially given what we know about the Delta variant?
Sure, wear masks. Look, the variants don't have pairs of scissors that cut their way through masks. They are blocked by masks in the same way that the previous variants were. You know, they don't burrow through the mask. So wearing masks in high-risk environments makes sense. I have to wear a mask when I go out of my office into the main medical school. It's a mandate. It's a medical school, it's a hospital, there are patients, we wear masks. I don't wear one walking down the streets of Manhattan where I work because I don't feel a need to do it, being fully vaccinated. If we're in a bar or a restaurant, there is now a mask mandate, and that's appropriate because people can still be infected. And, you know, people say wearing a mask is inconvenient. Well, it's inconvenient, yeah, but what's really inconvenient is wearing a ventilator. You do not want to be wearing a ventilator on your face. That is really incredibly inconvenient. And it's also incredibly inconvenient for your family to have to bury you or take you home from a very severe bout of COVID. It's very inconvenient to open your medical bills, which are going to be ginormous even after the federal government has picked up a lot of expenses. So I kind of don't get this refusal to wear masks. It's so much wrapped up in the politics of the pandemic and this freedom. I do not want my children muzzled. I know best for my kids. I'm a parent. It's my decision. I don't buy into any of that. I think there are strong public health reasons to protect your children, protect the children around the children, to protect the teachers have to protect the children, and the same in other work environments. There is, to my mind, there is no excuse for not wearing a mask in a high-risk environment, which may not be walking down the street, but indoors where there are lots of people around you, then absolutely wear a mask. It's not that inconvenient.
Thank you. So we have several more questions that have come in while we've been talking. So you said that there would be up to 200,000 Americans who will be dead by Christmas, all of which will be among those who are unvaccinated. Do you have a sense or an estimate of those deaths? How many would be unvaccinated?
Though I said that, I mean, 100 to 200,000. I mean, I'm
sure.
not.
Yeah.
But you know, we're now at around, I think, 600 deaths a day at the moment, according to the New York Times tracker site. Well, you just do the maths. There are a certain number of days left in the year. There's a certain number of people dying each day. It's going to go up. It's just a simple numbers calculation. Almost all of them will be among unvaccinated people. I mean, some vaccinated people will unfortunately die, particularly people who respond poorly to the vaccines. And we can come to that because some people do. But the overwhelming majority of those who are yet to die, just as those who have died in the last month or so, are the unvaccinated. It's undeniable. It's just factual information that has emerged and will continue to emerge. So fear of death is a major behavioral driver. If people are persuaded that they are at serious risk of long-term ill health and dying, if they have received that message, they tend to respond because nobody likes to die or nobody likes to be in an ICU, and their family members don't like it either. So the more stories that the media promulgates about people who've refused to be vaccinated and are now dying as a result, I mean, I don't applaud the fact that that's happening, but I applaud the stories because it's a major driver. People need to see it in their communities. I mean, here in New York City, March 2020 was a salutary experience for everyone. You know, I saw the morgue vans outside the hospital. There was overflow. You had to put the bodies somewhere. I mean, that's a behavioral driver. But in some parts of the country, they didn't see that. So in rural areas, you don't necessarily see that. It's when you read and hear about your neighbors and friends dying or suffering severe consequences, it tends to make you think, and while, if, at least for the individuals who are capable of rational thought, and there's a significant percentage of Americans who are outright vaccine refusers, and there's not much you can say to persuade them to do the right thing. It's the hesitant, the ones who need their hands holding, need persuasion, need questions answering. They're the ones that are the most susceptible target population for better education. But if you believe that a vaccine will turn you into a human magnet or will turn you into a zombie because you saw a movie, there's not a lot you can do about that. I mean, that's a mindset, that's the QAnon mindset that you can't penetrate because it's not rational.
When will the FDA, when do you think the FDA will approve the vaccines, and why does that matter? Something coming up in some conversations with people who are hesitant.
It's this pesky emergency use authorization versus full approval. I mean, to the professionals, it's a distinction without a difference. It doesn't matter to us, but the public seems to have glommed onto this idea that emergency means that they were approved without proper safety evaluations and it was all done in a rush. Well, it was done in a rush. There's a pandemic going on. But that doesn't mean that safety evaluations weren't done. It doesn't mean that corners were cut. Time was saved in many ways, and get into all the technicalities of how timelines were compressed. But it doesn't mean that safety details were not accumulated, and safety details have been accumulated over the past year. And a full approval, I mean, I read that the Pfizer and Moderna or whatever, they have to submit 100,000 pages of documents to the FDA. Well, somebody has to read that. I mean, the FDA got hollowed out last year. A lot of, like the CDC, a lot of staff left during the Trump pandemic just because of the climate they were put under as government employees. So you lose key staff. You have a huge amount of work to do. You have 100,000 pages. You've got to assess it properly. It does take time. We all wish the FDA would do it quicker, no question about it. But the wish and the reality may be two different things here. So, you know, best estimates, Pfizer got theirs done first, filed first. It's probably going to be within a matter of weeks. I mean, certainly the Biden administration has been putting the screws on the FDA to get the approval done. I have little doubt that it will be done. And, you know, surveys show that some members of the public will trust it more if it's had a traditional full approval. Like I say, to me, it doesn't matter, but I'm not the target population. If people get more confidence, then bring it on. Let's get it done and let's tell them that it's fully approved.
Okay. We've had a few questions come in, and this is something we were chatting about right before the session began. Can you talk for a moment about some of the common misconceptions about the need for boosters or additional shots? Hearing a lot about this in the news lately.
Yeah, absolutely, we are. Well, a couple of weeks ago, oh God, was it a couple of weeks ago? Time's so blurry nowadays. I mean, last week, the CDC approved dose 3, booster, whatever you want to call it, for immunocompromised people. And that's absolutely the right thing to do. There's around 1 million Americans who have medical conditions that mean that they don't respond well to vaccination. They can be transplant recipients on immunosuppressive drugs. They can be cancer patients, particularly leukemia, lymphoma patients. Some cancer therapies are immunosuppressive. Some people have genetic conditions that are problematic. So they don't respond well to the vaccines, but studies done in the USA, well, around the world over the past 6 months show that a third dose can significantly increase their antibody response. Not every patient, not every immunocompromised person. Some people just will not respond no matter how many shots you give, but a significant number will benefit. And CDC has seen this and found a way to lever that into the conditions of the EUA. So that's already started as of, I think, this week. Now there's stories in the media that the FDA is going to approve, or CDC and FDA are going to approve third doses for Americans probably in mid-September. I mean, I think that's going to happen. And the argument is that 8 months after the initial rollout, or thereabouts, it's time for a third dose. Well, you know, that's fine. It would be handled, I'm sure, in the same way that the December-January rollout was. So the first people will be healthcare workers, nursing home employees, then the elderly, I mean, probably defined as over 70 as it was in December. They will be the first priority, and that's as it should be. 2 reasons. 1, they're the most in need, and 2, they got the first dose first. So, you know, they've had a longer period. So that I think will happen. And people in their 20s who got vaccinated in April and May, they're not going to get a booster in September. They will wait another period of time. And again, that's appropriate. So immunity does wane over time. It doesn't fall off a cliff. It's a gradual process. And at a certain point, CDC and other national agencies track this information, get an assessment of the degree of waning, and the magnitude is, when the magnitude is sufficient for there to be a problem, then you take action. Then the Delta variant is more problematic. So if you're seeing a reduction in vaccine efficacy at the moment, it's a combination of immunity waning over time and the Delta variant spreading. Plans have been put in place and they're going to be executed, it would seem, from September on. And I don't see anyone who thinks this is a problem. I mean, there's been a debate over the summer, not about whether there should be a booster, it's about when. And there are a lot of what I call the worried well around, or the neurotic, people who are just obsessional about their own health and are convinced that they're at risk when they're really not. And, you know, they talk to the media and they send emails to the government and so on. And I get them all the time. And, you know, you have to try to persuade them that they're not as at risk as they think they are. And it's a difficult thing because people are concerned about their own health, and some people are very concerned about their own health. But anyway, the boosters are going to come later this year, and in a staggered, scheduled, equitable manner, that the people who most need it will get it first.
Let me ask you a follow-up question that just came in. This is local, but I believe you're in New York City. Is that right? So you may know, you may be able to answer this. So New York City says moderate to severe immunodeficiency is the qualification for the booster, and that to get it, you need to attest that you have a qualifying condition. Do you have any idea if that's going to be a verbal attestation or providing documentation, or how New York and other cities and states might deal with this?
I don't know how this is going to be dealt with. And I'm sure a lot of people are going to exaggerate the severity of their conditions. You know, ideally it would be handled by physicians under a prescription. I don't know how it's going to work on the streets, but I'm sure there are going to be people who just say, I am willing to attest that I am immunocompromised, give me a vaccine shot. I mean, we've seen this throughout. There were all sorts of people who found ways to jump the line in December and January. I mean, you know, often money talked or powers of persuasion talked. I mean, it's going to happen. I read a stat in, I think, the New York Times over the weekend that 1 million Americans have already got a dose 3. They've found a way to game the system. This is America. People do that. I mean, I'm sure it's the same in Europe. So, yeah, I don't know how it's going to work in practice, but I expect that a lot of people are going to be exaggerating the significance of their health problems.
Okay, so I'm going to ask a couple non-booster questions that have come in. We might get back to the boosters anyway. Does the vaccine lower the risk of transmission?
Yeah. Up until very recently, I would say that was absolutely certain, because it lowers the risk of infection. And if you're not infected, you're not transmitting. Now we have a bit of a gray area because it's emerging knowledge. So can people who are vaccinated, when they get infected by Delta, can they pass that infection on to others? There are plenty of anecdotal cases of that happening. But anecdotes are not solid numbers on this. So we know there's more of a problem than there was, but we don't know the magnitude of the problem. And that's really as much as I can say. We know it's happening. We don't know the extent to which it's happening. But there's a reasonable assumption. If you get infected, always consider yourself a transmission risk for other members of your household. I mean, if you're infected, you should be at home and not going to work or going to bars. The problem is, of course, if you're asymptomatic and then you don't know it. But if you've got demonstrable symptoms, you should not go out, and be conscious that people in your own household may be at risk. But if they're also vaccinated, their risk is mild COVID. It's not really severe COVID and death, but you have to assume that you're transmissible, even if perhaps you're not.
Okay. Based on how Delta has devastated other countries and then abated, how long do you think Delta will be the most present strain in the United States?
That's another interesting angle, because both the Indian pandemic and the UK pandemic were very sharp for Delta, very sharp up and very sharp down. And that's still being, looked at, because it's an interesting pattern, and it'd be informative to understand why. And it was similar in both countries, and yet India was hardly vaccinated and Britain was quite well vaccinated. So, it's not just the influence of vaccines. I mean, I have a hunch about it, that there is a subpopulation of humans that is particularly susceptible to Delta due to some, host genetic factor. But that's not far off brain fart. I mean, I can't prove that's true, but there might turn out to be people who are particularly vulnerable, and others who are just typically normally vulnerable. But it is an interesting observation, and I don't know anyone who has an answer to it at this stage. So it might be that The US pandemic for Delta has not peaked. I mean, the caseload is going up day by day by day, particularly in, in the states of the South where under vaccination is the problem. But it's not really taken off yet in the Northeast and California, not to the extent that we saw with Alpha in the winter. And is that only due to greater vaccine uptake, or is it just a matter of chance? I mean, I read a really fascinating article in The Atlantic, literally over lunch, that raised that as an interesting unknown. Why do we not know the answer to that? And I don't know anyone who does, but I do know it's the kind of information that scientists nationwide are interested in and trying to find the answer to.
So a couple questions have come in about other variants, and one that I know I've been hearing about it a little bit more lately is the Lambda variant. So can you talk for a minute about Lambda or other, I know this is a Delta session, but about Lambda or other variants that we are hearing might be more contagious or more transmissible?
Well, Lambda is relatively unknown at this stage, and it's also a relatively minor problem, but it's on radar screens. It originated in, I think, Colombia. It was one of the South American countries, may have been Peru. I tend to get a couple of these mixed up. And it's been seen in southern Florida, probably due to immigration from travelers from flying into Miami from South America, which is a transport hub. So far it doesn't appear to be out-competing Delta. It does have antibody resistance properties that look similar to Delta. Is it more transmissible or less transmissible than Delta? We don't know. But these variants are tracked, and it is definitely one that the scientific community and epidemiology communities are now aware of. The most antibody-resistant ones are Beta from South Africa and Gamma, the one that originated in Brazil. But as I said earlier, they essentially have vanished because Delta's just outcompeted them.
So there's a lot of discussion about younger persons being resilient. So when you think about college students who are vaccinated, and some of our learning community members are specifically focusing on young adults, we're actually going to do a young adult series next month of learning events. What do you estimate the risk to be to the vaccinated college students, given close environment with large numbers of people who are likely to not be vaccinated? So any thoughts specifically on messaging or targeting or risks for young people?
Well, there is this notion that young people, bullets just bounce off me. I'm not going to get this virus. I've got a strong, healthy immune system. I'm amazing. I'm wonderful. Not my problem. And, it's one of those things that's true to an extent. I mean, we've known since the start of the pandemic that most people with severe illness and death are older, or people with severe medical conditions, which tends not to be apparent in the younger population. But it's also been apparent right from the start of the pandemic that kids and young adults can and do die of COVID. I mean, there are something like 500 children who've died of COVID in America. There are plenty of examples of young adults who think they're, bulletproof until they find out that they're not. And Delta is infecting more younger people and children than the previous variants, again, because of the same dynamics. It's more transmissible. So you're more likely to acquire a dose through the nose and mouth that is going to cause you a severe problem. So yeah, there's a relative invulnerability of younger people, but it's only relative. And there are plenty of examples of people who found out that they were not as bulletproof as they thought they were. So, and you can be asymptomatically infected and transmit the virus to an older person you come into contact with. I mean, last summer there were outbreaks in college towns where students had been, behaving as students do, going to parties and whatever, and we all did it, and infecting older people they came into contact with. And the older people in the college towns were the ones who were sickening and dying, and we're getting really quite annoyed about it because of the behavior of the students who are, as students often are, somewhat irresponsible. Well, increasingly, colleges are putting in vaccine mandates. or, you know, vaccine persuasion methodology, or whatever you want to call it. In some states, they can't put in mandates, but I've seen all sorts of, you know, gimmicks to try to get students to do the right thing. And it's important. But you have to persuade them that you might think that you are invulnerable, but plenty of your peer group thought that, and here's examples of what happened to them. You know, they finished up on a ventilator. She died. He has long COVID. You know, making them realize that nobody is truly bulletproof.
So on the topic of persuasion, this is a two-part question. So there seem to be a lot of unvaccinated people who want to wait and see before getting vaccinated. That's a kind of common response for vaccine hesitant. And many have said they would get the vaccine by the end of the year. So the first part of the question is messages that you think are most effective in speeding up their timeline to get vaccinated and do it now rather than wait. And then related to that, is there now over a year of data from the clinical trial participants that could show longer term effects don't develop from the vaccine, since a lot of people seem to be using that 1 year as a significant marker?
Well, you know, a simple glib answer is, how long do you want to wait? How many people do you want to see die around you? How many people do you want to see get long COVID around you? How much evidence do you need? Again, it's this fear of disease and death as a driver. And with Delta surging in the South, particularly, more and more people will see the consequences of waiting. And if you wait too long, you miss your opportunity because the virus gets you before you've got yourself protected. So, you know, that's the kind of arguments that I would use. At some point, your waiting is going to run out because you've waited too long and you've made a mistake that could be fatal. 1 year, you know, what's the difference between 364 days and 365 and 366? It's arbitrary. It's a line in the sand. The first people were vaccinated in around June of last year, something like that. And there's now, therefore, well over a year of safety information and clinical trial experience. And yes, there have been side effects. We can't ignore the fact that there have been blood clotting disorders with AstraZeneca. J&J. AstraZeneca isn't used in the States. There have been very rare and generally mild myocardopathy, myocarditis with the mRNAs. But again, if you look at the numbers game, the risks of dying of COVID vastly outweigh the risks of having a severe vaccine side effect. And, you know, some of the stuff that goes around about long-term, the mRNAs are going to change my DNA, and, you know, this zombie argument. I mean, you can turn you into something that you're not, or the Russians have spread misinformation that it can turn you into a monkey and all sorts of, you know, nonsense. There's little you can do about that. But the long-term evidence is that these vaccines are incredibly safe. And the vaccines didn't come out of nowhere. They weren't suddenly developed in March of 2020. They were repurposed from technologies that we'd had up to a decade or longer experience with. Most of them came out of HIV vaccine programs. And so we knew the technologies and the companies and scientists involved could repurpose existing methodologies to target specifically this new virus. But the technologies are out there. I mean, it's like a car, you're putting new wheels on it, but it's still a car. So it's not like we had no experience of the safety of the technologies. So it's not just a year. You can track mRNA vaccines, which are the newest. Even they date back to about 2012 when they first started to be seriously looked at. So yeah, you can wait and you can watch what's happening around you. And at some point your luck's going to run out. So at what point do you want to change your mind? I mean, every day you're taking an additional risk. Why do it?
Okay, somehow 40 minutes have already passed. So I'm going to do one more question from the Q&A, and apologies, there are many that we're not going to be able to get to, but we are recording all of them, and we'll try to answer them as we can in additional events and through conversations on our website. So I do want to say that to anybody whose question has not been answered. But Dr. Moore, what would you say to communities of color, which you know is the target population for our learning community, that are hesitant to be vaccinated due to historical mistreatment by the health system?
But 2020 and 2021 are not the 1950s. That science is more understanding, it's more race neutral, it's more respectful of populations and their specific needs, that we are not the people of the past, that what our predecessors did to you is not what we do today. And the most effective advocates for communities of color are people of color, because there's more of a trust. They're more likely to trust a Black woman or a Black man than they are me. And that's entirely right and entirely reasonable. So you target the professionals to their communities, but medical science is not today what the shame of the past was. Everyone's learned a lesson on what not to do, and it's not done nowadays, not by any professionals that I ever interact with.
Thank you very much. We have just a couple of minutes left, and we would like all of our participants to help us out by, before we close, participating in a very quick satisfaction poll, which we are going to be including in all of our learning events starting today. So Alicia or Luis, can you pull up our polling question before we end? This will only take you a minute, and then we will officially thank Dr. Moore and close. So if you wouldn't mind just taking a moment to fill this out. Dr. Moore, thank you so much for taking the time. Clearly, from the volume of questions we didn't get to, there's more than a dozen still in the queue. There's lots of interest in this, and I at least for me, this has been helpful, and I think it looks like many of our audience members agree. So we appreciate your time so much.
You're all welcome, and if you see a need to do it again, just reach out at any time. Good luck to you. Truly appreciate everything you're trying to do here.
All right, and like I mentioned to the learning community members, we will be able to, we will circulate materials from this event, which will be a recording and a transcript, because there are no PowerPoint slides. And then we will also we're in the process of planning additional events, office hours, and hopefully an event that's more focused on messaging, and maybe even highlighting some things that that you, the community members, are doing specifically around Delta variant and outreach and messaging that is resonating with the communities that you are working with. So on behalf of the learning community, thank you for attending our event, and we hope to see you again soon.